Welcome everybody. I am Lluis Blanch from Sabadell, Spain, and I would like to speak about brain-lung interactions in the critical ill. And first, I would like to thank the Egyptian Critical Care Society, and in particular, Dr. Soliman, Mokhtar, and Abbas for this kind invitation to be here today. I will speak on brain-lung interactions in the critical ill. I would like, first of all, to share this scheme about these two organs that they are interconnected. Of course, there are common injurious factors that can act on both, but there are injuries that came from the brain to the lungs, such as when there is an injury, in that case to the brain, because there is an increase in intracranial pressure, which catecholamine release, neuroinflammation, hyperdopaminergic states, and so on. And also from lung to brain when there is injury in the lung caused by, hypoxemia, hypocapnia, when there is an impairment in respiratory system mechanics, neurotoxic, or release of inflammatory mediators, asynchronous, dyspnea, and so on. If we go a little bit further with this scheme, okay, we can go to this revision that was published several months ago in a British Journal of Anesthesia, where here we describe from, in that case, the lungs to the brain, several mechanisms. And you can distinguish here the circulatory pathway and the neural pathway that can cause increase in respiratory drive, cell activation, can, in that case, promote inflammation and also apoptosis. But the opposite also occur from brain to the lung, where it can cause an increase in asynchronous and also an increase in that case in the vascular tone, inflammation in the lung, and also increasing in or impair phagocytosis, as we will see. Nicely, when there is a parasympathetic, in that case, activation, it modulates inflammation. So let's talk about brain to lung with commenting some now several year papers. This is an investigation that we did together with my group, trying to prove that there is some predisposition in the lungs to be injured when there is severe injury to the brain. These are two groups of rabbits. The control group with severe brain injury. The control group is control, and then another group with severe brain injury. And you will see here that after 2 hours comparison, there is not much different in all these parameters related to oxygenation or related with respiratory system mechanics. However, when we took out these lungs from control animals where the brain is not injured, and the brain injured animals with severe brain injury, and we just control perfusion pressure, and as here, and control the pressures in the left atrium and in the pulmonary artery and in the left atrial, then we have the following. These are the parameters that we use, and then we found that those animals ventilated with pressure control, 30 and PIP5, that had, in that case, the brain injury, then they present an increase in lung edema. And this is the picture. There is the increase in lung weight, which is lung edema. And here you can see, those animals that show a stress failure of the pulmonary capillaries compared with to control. So the brain predisposes, when there is injury in the brain, the lung to be further injury. And this also is nicely depicted here in this scheme. When there is brain inflammation, there is systemic inflammation at the same time. And then there is an increase in alveolar capillary permeability because there is sympathetic inactivation. But also, this brain inflammation acts in that case to the lung parenchyma because there is an increase in mediators and a reduced phagocytic capability, an increase in this inflammatory inflammatory, cytokines. Therefore, we need to pay attention in these patients that they had injury, hemorrhage, or trauma, because the lungs are seat for inflammation. And in fact, is what is demonstrated here. The same group provoked focal ischemic stroke in experimental animals. And after 24 hours, as you can see here, those animals that they had the stroke, there is an increase in tidal volume. And this increase in tidal volume was provoked by increase in the respiratory drive, because in the stroke group, as you will see here, there is more damage in the lung parenchyma, more edema, more inflammation, more atelectasis, and also the diffuse alveolar damage score was higher. Therefore, this has been demonstrated not only in animals, but also, as we will see later on, in humans. Again, from the same paper, when they compare in the brain tissue, in lung and brain tissue homogenates, here the brain and here the lung, there is an increase in these inflammatory cytokines in the group of a stroke. And again, the phagocytic capability in that case of the alveolar macrophages was decreased in the stroke. So the probability of this lung, to get injury and more infections was higher. Again, the group of the Pelossi and Michael Quintal show us some CT scans of the lung in animals after acute increase in the intracranial pressure. As you will see, there are some densities, and in animals with RADS that after acute increase of intracranial pressure, these densities augmented. You see here densities in animals with RADS plus brain injury compared with only RADS, and there is an increase, and as you will see here, in those densities. Similar happened in control and animals with only brain injury in the lung densities. This is important because this in humans may translate in organ failure in other organs. The group of Mascia show in more than 300 patients, compare patients with the Glasgow Coma score higher than 8 or equal or lower than 8, that the ones that they have more brain injury, the probability in that case in have respiratory complications, that's higher. Again, indirectly showing that these lungs are predisposed, are set in that case to suffer, inflammation or injury when the brain is already damaged. And similarly, in this series of almost 700 patients with acute, in that case, spontaneous intracerebral hemorrhage, that they have risk factors to develop acute respiratory distress syndrome. And these factors were when the tidal volume used higher than 8, because in this lung predisposition, also was added the potential of lung injury due to high tidal volume, and also when they get, red cells, or when fluid balance was higher, or then after exposure to frozen plasma. So we need to take all those factors to protect, in that case, the lung and other organs in patients with severe intracranial hemorrhage. And moreover, this is the nice paper again of Luciana Mascia, when in potential lung donors were randomized to conventional ventilatory strategy, non-lung protective 10-12, and a protective ventilatory strategy. Then using lung protective strategy in these potential organ donors with brain death, increase the number of eligible and harvested lungs compared with a conventional strategy. Again, in those lungs that they are predisposed, in that case, to injury, we need to protect them in order to, in that case, to be used for further lung transplant. There is also importance now in the COVID times to see how is the relationship of the SARS-CoV-2 virus in that case with the other organs. We know that the virus can cause lung damage. But interestingly, through several mechanisms, also it can damage other organs. You can see here that through all these mechanisms, it can cause, cytokine release, microvascular dysfunction that can affect not only the heart, as we know, the liver, the kidney, or skin, but also the brain injury. In these very interesting papers, there is also a review on different treatment options, for further control in that case, to improve outcome of patients and further control, in that case, the pandemics. Having said that, it is also important to see that the virus, through, neuroanatomical structures like olfactory, in that case, nerves, can enter, to the brain and can, exert some injury to the respiratory center, or in that case, to the precortical structures of the brain. Here, you see this is copies of RNA of the virus in the different brain structures, and you see here that in the medulla oblongata, which is the respiratory center, it can be found. Therefore, the SARS-CoV-2 virus appears to follow all these neuroanatomical structures, penetrating in defined neuroanatomical areas, including the primary respiratory and cardiovascular control centers in the medulla oblongata. Today, the consequences of this, still, in that case, it is unknown. Again, there's this neuroanatomical inflammation caused by this viral neurotropism, to the brain, can have clearly a brain-lung crosstalk. It can have, in the lungs, some inflammation from the brain, but also from the injured lung, where is impairment in mechanics, in gas exchange, oxidative stress, from here, in that case, to the brain. Therefore, we need, in COVID-19 patients, to protect also the brain and to protect also the lung. So let's comment some effects from lung to the brain. And here I also refer to one paper of our group where we were interested to see if we use non-protective ventilation, let's say high tidal volume, if there is anything activation in that case in the brain. And then what we used to analyze was the C-force, an early gene in certain areas of the brain. So we measure regions of interest, such as those depicted here in the brain bracts. Interestingly, we have found that in the central amygdala, where is the place where the injury can cause cognitive impairments, high tidal volume express this early gene. Similarly, happen in the retrosplenial cortex, as you see here, where injury causes memory deficits, and also in the thalamus, where the function is the interpretation of the sensory information. Again, here there is the high tidal volume. But look at that. Sometimes in a spontaneous breathing animals also, such as here, the C-force can be increased. So maybe if these animals, in that case, get some higher drive, it can also, reflect this pattern of C-force activation. This, again, this needs to be demonstrated. And here, just to comment an interesting article where, these authors analyze the effect of mechanical ventilation in animals with Alzheimer's disease, transgenic animals with Alzheimer's disease. And you can see here that when there is, mechanical ventilation, this, protein causing Alzheimer's is activated compared with the spontaneous breathing animals. And this is quite important because there are mechanisms that it seems that mechanical ventilation can trigger, in that case, some protein activation in the brain. These findings provide mechanistic insights into the well-documented clinical observations that associate mechanical ventilation with long-term cognitive decline and Alzheimer's disease in particular. Of course, this needs to be further explored in humans. Another example is what happened in patients after cardiac arrest, where out of hospital, the resuscitators employ lower or higher tidal volume during the first 48 hours in the ICU. These investigators, divided in those with low tidal volume compared to those with high tidal volume. The threshold was 8 mL per kilogram. And what they found is the probability of discharge with favorable neurocognitive outcome, in that case, was higher when the mechanical ventilation was protected. Similar happened they were more ventilator-free days and more shock-free days. Again, what we do in the lung projects in that case to the brain. Again, another argument to protect both organs. And finally, just a word on the neuroinflammatory reflex. So when there is an inflamed zone in any part of the body, there is information that goes to the brain, and the brain reacts, through three ways: the humoral pathway, the sympathetic pathway, and also the acetylcholine pathway, because there is an anti-inflammatory effect of the acetylcholine. So there is the anticholinergic anti-inflammatory pathway that prevents, that controls inflammation in inflamed zones in the body. The group of Dos Santos and Slasky designed a very nice experiment. If this neuroinflammatory reflex is mediated by the vagus nerve, they designed this experiment doing vagotomy and then applying high tidal ventilation in animals with induced acute lung injury. You will see here, this is in red is the vagotomy, the animals with vagotomy in low and high tidal volume. High tidal volume plus vagotomy experimented the higher levels of injury, more neutrophils, more inflammatory mediators such as IL-6 cytokine, and in the lung tissue, the apoptotic index was higher. When the same group, in fact, what they did is administrate a vagus mimetic drug, so potentiating the effect of the vagus using semapimod, the effect was the opposite. Animals with placebo had greater edema compared with less edema when there is animals with semapimod, treated with semapimod. And similar happened in that case with less neutrophils, more macrophages, and less inflammation. To conclude that in experimental ventilator-induced lung injury, vagotomy exacerbates, while vagus stimulation attenuates lung injury. In rats ventilated with either high or low volume strategies, treatment of both mice and rats with the vagus mimetic drug, semapimod, result in decreased lung injury. Maybe this, will be the pathway for further treatments to mitigate ventilator-induced lung injury. Now we need to add another organ, which is the heart, because we are talking about brain and the lungs, but the heart is very important in certain situations when there is mechanical ventilation, and I will refer to the use of PEEP. And I took this interesting information from Battaglini and Pelosi paper, because now the crosstalk is between brain, lung, and heart, normal lung. In normal lung, the relationship between mechanics, heart function in terms of venous return and cardiac index, and low PEEP is such as here. So in low PEEP conditions, if driving pressure, plateau pressure, transpulmonary pressure is normal, together with the normal oxygenation and oxygen transport, nothing happens in heart, and it's normal, intracranial pressure, oxygen delivery, and cerebral perfusion pressure. However, in high PEEP, since there is overdistension, increasing intrathoracic pressure, increasing driving pressure, increasing PEEP, venous return, it's decreased. Cardiac index is decreased. And in that condition, in the brain, there is an increase in intracranial pressure, decrease in the oxygen transport, and also decrease in the tissue oxygenation, and decrease in the cerebral perfusion pressure. Such happen in normal, but in the RADS lung, when there is low PEEP, is quite similar of what we observe in normal lung. However, in high PEEP, if this high PEEP, in that case, do not produces recruitment in RADS, this increase in plateau pressure and maybe decreasing compliance, then it will impair, again, venous return, impair cardiac index, and maybe will impair, cerebral mechanics. However, if high PEEP causes recruitment, this picture will probably change, and maybe the effect of intracranial pressure will stay the same without impairing oxygen transport to the tissues and to the brain, and without impairing cerebral perfusion pressure. The message here is that in RADS lung, when there is an injured brain, we need to monitor brain parameters, heart and circulatory parameters, and respiratory parameters. And in COVID-19, the picture is even more complicated. In low PEEP, and this is this tremendous heterogeneous lung mechanics of the COVID patients, it may cause either recruitment or overdistension, and this, will reflect here. However, when we increase PEEP, if we cause severe, in that case here, overdistension, and there is an impairment on hypoxic vasoconstriction, you will see that, there is a dramatic impairment in lung mechanics, a deterioration in the hemodynamics because there is a huge decrease in venous return, as a situation, a huge increase in intracranial pressure, and a decrease in the cerebral perfusion pressure. All these two means that the brain now is predisposed to injury, and also, the lung is predisposed to injury. And if we want, again, to further complicate that, we can go not only to the heart, to the brain, to the lungs, and to the intra-abdominal pressure, because when there is increase in the intra-abdominal pressure, there is an increase in the flux of cerebrospinal fluid that will cause an increase in the intracranial pressure and a decrease in the pulmonary perfusion pressure. Therefore, look always in these four organs: the brain, the lung, the heart, and the intra-abdominal pressure. Then, during mechanical ventilation, and the brain and the lung, they are connected, but also they are connected for dyspnea, for discomfort, for anxiety, for lung injury, muscle injury, and all these will affect cognition, sleep, and post-traumatic stress disorder. Now we know, and we are studying these patients, mechanical ventilation. Patients on mechanical ventilation can experiment more delirium, can experiment more anxiety, more stress disorder, and more cognitive alterations. In fact, during the ICU stay, the patient is extremely frail. So it has, a stressful and traumatic environment, may have delirium, and may have mechanical ventilation. And this coined the term post-intensive care symptoms, which is weakness, cognitive impairment, emotional disorders. And these are chronic sequels 1 year after ICU discharge. Is this common? Of course, because in the world, maybe in a year, there are more of 38 million people under mechanical ventilation, and this can occur in these 38 million between 30% and 80%, and this costs money. So these are research that we have done in our group, say that if we have patients under mechanical ventilation and we do treatments in that case to stimulate cognitive repair and to trying to ameliorate the cognitive impairment, this is safe, And in these mechanically ventilated patients, when we have done just a small pilot, in that case, randomized control trial with virtual reality-based neurocognitive stimulation, I mean, to improve cognition compared with the control group, you see that here in this line is that, I mean, cognitive stimulation seems in that case to work, I mean, with this patient present with more working memory index, and also 50% in the treated patient experiment, I mean, lower levels of anxiety and depression, although this is not yet significant, needs more studies compared with the control group. Therefore, now we have designed, now we are building software about that. And this is the new device that now we are going to test in the patient, in the patients at the bedside. I mean, this, I mean, combines cognitive stimulation exercise plus emotional support tools plus, you know, an alternative communicator for those patients that they cannot communicate. So this device, according to our research, is feasible and safe. We believe that can be, I mean, effective for working memory and anxiety and depression. So this is the kind of investigation that we are conducting right now. To conclude this talk, crosstalk always exists between lung, brain, heart, maybe, I mean, the organs inside the abdomen or other organs during critical illness. Therefore, we need to pay attention to all of them. Brain injury predisposes to lung injury, and the opposite is also true. Supportive treatments can exert effect on all these distant organs. That's why we need to think big. Virtual reality may improve cognition in mechanically ventilated patients. This is future research. And research on this area is in its infancy, but this knowledge can benefit patients, their families, and care providers. Thank you very much.